I would like to present to you the long-term results of fresh lenticle implantation in keratoconus patients, ultrastructural analysis by transmission electron microscopy. The shortage of donor corneas highlight the need for alternative treatments, and fresh lenticle transplantation has emerged as a promising approach to restore corneal thickness as well as improvement in visual acuity in keratoconus patients. In our study, our purpose was to evaluate the efficacy of lenticle transplantation in keratoconus patients and also investigate new intrastromal histological structures that develop after lenticle transplantation. And this study was approved by the National Research Ethics Committee of Kosovo. So in this study, we included 60 eyes, and they were divided into 3 groups according to their follow-up years as well as their preoperative corneal thicknesses. And corneals with thinner corneal thickness received thicker lenticles in this surgical technique, and all of our patients were stage 2 or 3 keratoconus patients according to Amster-Krumai classification. And our donor patients were with a refractive error of -4 to -9 dioptries. And also 5 samples in total were obtained from a non-treated keratoconus patient, a fresh myopic lenticle, and also treated keratoconus at 1, 2, and 3 years post-operatively. And in the surgical technique, we do not place the lenticle centrally, but rather according to high K value. And in this video, in the first half, a sample is obtained from a non-treated keratoconus patient, and then a lenticle with a refractive power of -6.5 was transplanted. And our goal is that after the surgery, the minimum corneal thickness is at least 460 microns for the transplantation to be more stable. And when we're transplanting the lenticle, it's important that the thickest part of the donor lenticle is placed on the thinnest part of the recipient cornea. And our cap thickness is 130 microns. And in the results, in all of our groups, the uncorrected and the corrected distance visual acuity improved significantly after the surgery, and the corneal thicknesses also improved after the surgery, and they remain stable. And the Q values also improved in all of our groups. And in our TEM analysis, in the first row, you see keratoconic samples, and the collagen fibers are very disorganized, and you can see the apoptotic cells as well. And in the fresh lenticle sample, the corneas, the collagen fibers are really dense and parallel to each other, and you can see the healthy cells as well. And in our postoperative years, you can also see that the healthy cells are present. And in conclusion, according to our results, fresh lenticle implantation is reliable and cost-effective surgery, and our electron microscopy results also show a good incorporation of lenticle in the recipient cornea. Thank you so much.
Good morning. Corneal regeneration with intrastomal stem cells in fresh myopic lenticle transplantation for keratoconus with 5-year follow-up results. This study aimed to demonstrate the presence and possible role of active progenital cells and teletocyte in human cornea. We have 60 eyes with advanced keratoconus underwent fresh myopic lenticle transplantation. After that, samples were obtained from patients with untreated keratoconus and treated keratoconus at 1 to 5 years post of fresh myopic lenticle transplantation. These samples were examined using immunohistochemical staining with CD34 antibodies to conduct morphological observation, identify and quantitative CD34 positive cells, specifically teliocytes, and double immunofluorescence staining for specific identification of teliocyte cells. Teliocytes are a new type of stromal cells, first described in Cornea by Marin et al. They are typically defined as cells with telepod, long extension by their ultrastructure features that are mesenchymal origin. Teliocytes are responsible for maintaining corneal hemostasis by supporting cell-to-cell communication, stromal organization, and tissue regeneration. This is a video on interstromal pocket we prepare according to topo guide. And fresh lenticle transplant. As you know, myopic lenticle, central thicker, recipient thinner area I planted. After operation, 5 years after, visual acuity increase, Q value increase, and central corneal thickness increase. Double immunofluorescence analysis to enhance teliocyte identification, we employed two double immunofluorescence staining. Marker used include CD34 and c-KIT, stemness marker, and CD34 and PDH-beta. This technique allowed for clear differentiation of teliocytes from keratocytes in corneal tissue microenvironment. You can see teliocyte. First picture, keratoconus samples. You see very low cells, live cells. Compared postoperative 1, 2, 3, 4, and 5 years, you can see high live cells teliocyte. Immunohistochemical analysis, you can see CD34 cells positive, much more postoperative. And this slide, you can see teliocyte CD positive 34 cells. And this analysis highlight dynamic change in CD positive cells density during postoperative corneal maturation. Progenital cells aids tissue repair, while keratoconus sample show persistently lower CD34 positive count, indicating pathological difference. This finding offers insights for improved corneal regeneration therapy across different post-treatment stage. Fresh myopic interstromal lenticle transplantation is a safe, cost-effective, and reliable procedure that increases corneal thickness, improves visual acuity, and facilitates corneal repair. These results suggest teliocyte and stem cell may be involved in corneal regeneration, but their direct mechanism needs future study. Thank you.
Good morning, distinguished guests. I'm Kayan, a final year medical student from the National University of Singapore, and today I'll be presenting a systematic review and meta-analysis on the combined use of low-level light therapy and intense pulse light therapy in patients with Meibomian gland dysfunction. I have no conflict of interest to declare. Meibomian gland dysfunction affects up to 36% of the global population, leading to tear film instability and evaporative dry eye disease. While artificial tears, warm compressors, and other pharmacological options are widely used today, in-office procedures like intense pulse light therapy, and more recently, low-level light therapy have emerged as alternative treatments. These therapies are posited to work via different mechanisms. IPL delivers thermal energy, softening mebum and improving gland expression, while low-level light therapy, on the other hand, is athermal and works through photobiomodulation, which enhances cellular metabolism and reduces inflammation. Despite their growing use, the combined efficacy of IPL and LLLT remains debated. Therefore, this study seeks to examine the therapeutic effects of combined low-level light therapy and intense pulse light therapy on the symptoms and ocular parameters of patients with meibomian gland dysfunction. Medical databases were systematically searched, and analysis was done using RStudio. A total of 12 studies involving 713 meibomian gland dysfunction patients were included in the final analysis. Of note, patients included were largely those previously refractory to conventional treatment. Moving on to key findings, the combined treatment resulted in a significant improvement in dry eye symptoms, as shown by a reduction in ocular surface disease index score. This was sustained even at 6 months post-treatment. There were also statistically significant improvements in tear film stability, with increased tear breakup time and lipid layer thickness observed at both follow-up time points. In terms of tear production as measured by the Schirmer's test, treatment was also observed to result in a significant improvement in Schirmer's test values as compared to baseline at both time points. While the improvements of tear breakup time and lipid layer thickness can be reasonably attributed to the warming effects of IPL, which facilitates better mebum flow, the observed increase in aqueous tear production is less likely to be a result of this thermal mechanism. Instead, it may be driven by the anti-inflammatory and stimulatory effects of low-level light therapy. These findings have also been seen in both preclinical and clinical studies that have been conducted. Interestingly, while improvements in meibomian gland area loss was seen within the first 3 months, this was not sustained beyond 6 months. One possible explanation is that meibomian gland atrophy may be largely irreversible, while low-level light therapy serves primarily as a prophylactic intervention to prevent further cellular death rather than reverse existing damage. Alternatively, the apparent decline could be attributed to inconsistencies in imaging results due to interoperator variability in using infrared mammography. However, given the limited number of studies reporting these results, this finding should be interpreted with caution. In summary, combined low-level light therapy and intense pulse light therapy in meibomian gland dysfunction led to improvements in dry eye symptoms, tear film stability, and tear production that was persistent up to more than or equal to 6 months post-treatment, as shown in current studies. Other findings include improvements in loss of meibomian gland area that was, however, not sustained over a longer period of follow-up. In light of these findings, a few limitations should be noted. Firstly, the lack of comparative studies limit this to a single-arm analysis, making it difficult to confirm whether these improvements are due to the intervention itself or other factors such as placebo. However, given that most patients included were actually previously unresponsive to conventional treatment, these improvements seem to be encouraging. Second, despite applying a random effects model, there was notable heterogeneity in patient populations and treatment protocols. In conclusion, this review highlights the potential of combined low-level light therapy and intense pulse light therapy in improving dry eye symptoms and ocular surface parameters in meibomian gland dysfunction patients. While statistical significance may not always translate to clinical relevance, the results are promising. Further studies should aim for longer-term follow-up, comparative designs, and a deeper exploration of underlying mechanisms. And with that, thank you for listening.
Hello everyone, I'm Wu Boyi, the second-year resident from the Changge Memorial Hospital, Linkou, Taiwan. So today my topic is ocular complications and treatment in patients with facial paralysis, a multi-institutional study in Taiwan. And I deeply thank Professor Chen Hongji for his guidance in this research. So we aim to identify the risk factors for ocular complications in patients with facial paralysis and to investigate their treatment approaches. So we obtained our data from the Chang'an Research Database between 2001 and 2022. We included a patient with facial paralysis using the ICD diagnostic codes. So in total, we included 36,000 patients. The mean age was about 50 years old, and half of the patients were male. The median follow-up time was about 5 years. About 1/5 of the patients were followed by an ophthalmologist. So we tried to identify the underlying etiology for facial paralysis, and we discovered that Bell's palsy was the most common etiology. More than half of the patients had this diagnosis, followed by 5% of the patients having stroke, 5% head and neck injury, 3% head and neck tumors, 2% brain tumors. Some of these patients underwent surgery for their tumor. 2% Reissenhang syndrome, also referred to as the herpes zoster oticus. 2% birth trauma, 1% otitis media. The rest, 1/4 of the patients, they had an undetermined etiology. About 1/10 of our patients had at least one ocular complications. So these include the problem of the eyelid malposition, such as the lagophthalmos or ectropion, and the resultant ocular surface problems, such as the corneal erosion, corneal ulcer. Some patients developed endophthalmitis, and unfortunately, a few of them later on had legal blindness. So we use the multivariate logistic regression model to identify the predictors of ocular complications. And we discovered that male gender, old stroke, and Bell's palsy were the protective factors against the ocular complications, while the aging and certain systemic comorbidities were the risk factors. Most of the etiology other than Bell's palsy also were the risk factors. The patient with Bell's palsy, they had the lowest risk of developing ocular complications, only 7%, while patient with a head and neck injury, they had the highest risk. About 20% of the patient had at least one ocular complication. So actually, the prognosis of these patients are largely determined by the underlying etiology, whether it is reversible or not. For example, in patients with Bell's palsy, birth trauma, or otitis media, from the literature, we know that these patients had high rates of recovery after proper treatment. While patients with stroke or Reissenhang syndrome, they have variable outcome because, for example, in Reissenhang syndrome, only half of the patients could achieve complete recovery. While patients having trauma or tumors, their outcome is often disappointing because the facial nerve may have been permanently damaged by the trauma, tumor compression, or even be sacrificed during surgeries. Regarding the treatment, about 1/10 of our patients received at least one surgery, including the botulinum toxin injection in 8% of the patients. 1% of the patients underwent a static eyelid surgery. Some novel techniques, which is the dynamic reconstruction, also referred to as the eyelid reanimation, that aims to restore the blink function of the patient, such as the muscle transfer or the neurotization. So 1% of our patients underwent these dynamic surgeries. A few of our patients underwent a corneal transplantation, and unfortunately, a few of them had a finally evisceration. So we try to compare the outcomes of these patients in those who received the static eyelid surgery to those who received the dynamic reconstruction. The literature has indicated that the dynamic reconstruction offers better corneal protection. And we discovered that the patient that received the dynamic surgery, they had a significantly fewer use of lubricants and fewer corneal ulcer-related admissions, and they require less ocular reconstruction with amniotic membrane or corneal transplantation within 6 months after the surgery. However, the dynamic group were also found to be significantly younger compared to the static eyelid surgery group. This may be the reason for their better outcomes. So in conclusion, Bell's palsy, the predominant facial paralysis etiology, poses a lower risk of ocular complications than other causes. Patients with a head and neck injury, they had the highest risk. And the surgeons may have preferentially selected the younger patients to undergo the dynamic reconstructions for better outcomes. So this is my presentation, and thanks for your attention.
Thank you very much. Do we have a quick question before we move to the next talk? Okay, otherwise, thank you. That was very interesting.
Thank you.
Yep. I'd now like to introduce the next speaker, who's talking on isolation and culture of human corneal stromal cells and co-culture of exosomes derived from umbilical cord and corneal stromal cells, and it's Dr. Ashok Sharma. Thank you.
I will be speaking on exosomes derived from co-culture of umbilical cord and corneal stromal cells and their effect on corneal stromal cells in vitro wound healing model. I have no financial disclosure. We know that the corneal injury and the corneal epithelial defects, once they heal, they leave the scars, and significant scarring leads to visual disturbances. Exosomes generated from the umbilical cord, corneal stromal mesenchymal cells, have been found to have unique property to control inflammation, promote cell proliferation, and speed up the wound healing. Exosomes generated by the mesenchymal cells, they are the smallest extracellular vesicles, and they can transfer the functional cargoes such as proteins, DNA, RNA from donor cells to the target cells. Objective of this study was to investigate the effect of novel combination of exosomes isolated from culture of corneal stromal cells, umbilical cord cells, and their co-culture on corneal stromal cells on wound healing in vitro model. We have used the residual post-keratoplasty donor rim after penetrating keratoplasty. We used the precipitation method to extract the exosomes, and wound healing was determined by the in vitro scratch assay method. And also we determined the effect of exosomes on proliferation of the corneal stromal cells by using MTT assay. So the stroma was cut into 3 small pieces, and it was placed in the media, and fibroblast growth was seen after 6 to 7 days. We can see elongated and spindle-shaped cells in this picture. All the positive markers of the stromal cells were detected on corneal stromal cell by flow cytometry. Morphological analysis of the exosomes was done by transmission electron microscopy and dynamic light scattering, and it was found that the size of the exosomes were 30 to 150 nanometer in size, and these were the other parameters. In a typical wound healing assay, a wound gap in a cell monolayer is created by scratching, and that's the same we have done. And we have seen that top one is the control, where we have not used anything. Number 2 is where we have used exosomes from the corneal stromal cells. And number 3 is where we have used exosomes from the umbilical cord. And number 4 down is where we have used the combination from the co-culture of corneal stromal cells and umbilical cord, and we can see that there is faster healing in the co-culture of combined. The percentage of cell migration of the wound closure details were also they were determined, and when we compared to the exosome located in their individual culture medium, and we found that exosomes derived from corneal stromal cells and umbilical cord, they had significant higher cell proliferation. Cell internalization of the exosomes are also determined on fluorescent microscopy, and the successful uptake of exosomes by corneal stromal cells was observed. The first picture is the cells, the nuclei. The second one is the exosomes from the combined corneal cells and this thing. And then the third picture shows the take-up of the exosomes by the nuclei. Human corneal proliferation of the human corneal stromal cells by MTT assay was also determined, and exosomes isolated from the co-culture of showed highest proliferation. So we have seen that the exosomes have advantage, and they have better safety and longer preservation assay, transportation, lower immunological potential. We have certain limitations of this study. There is a lack of sterilization, and this exciting, ever-evolving field of exosomes-based therapy in wound healing needs more research and more studies. These are some of the references which I have used. Thank you so much for patient hearing.
The therapy into the clinic?
Timeline for the exosomes?
Yes, yes.
Yeah, we get 6 to 7 days after the culture.
Mm-hmm. Okay.
Thank you.
Thank you. Okay, we might move forward. So the next talk is by Ling Liang, and it's on ocular surface characteristics of congenital
Good afternoon.
isolateral gland agenesis. Is the speaker here? Liang.
I'm Dr. Lingyi Liang from Zhongsha Ophthalmic Center. It's my great honor to present here. In recent years, we saw a series of 5 patients with congenital isolated.
Sounds like it's going to be a recorded talk, so we'll just wait for that to come up.
Afternoon. I'm Dr. Lingyi Liang from Zhongsha Ophthalmic Center. It's my great honor to present here. In recent years, we saw a series of 5 patients with congenital isolated lacrimal gland agenesis. And today I would like to report the interesting findings and the possible crosstalk among lacrimal gland and the ocular surface. I have no financial interest to disclose. This case series includes 5 patients, 1 male and 4 female, aged 1 to 56 years old. By MRI, bilateral lacrimal gland agenesis were diagnosed in 3 cases. Unilateral lacrimal gland agenesis were diagnosed in 2 cases. Sjogren syndrome were excluded in all cases. Whole exome sequencing for genetic mutations were also negative in all cases. The symptoms were noted at age 1 to 20 years old. The patients with bilateral lacrimal gland agenesis tend to have symptoms earlier than those with unilateral lacrimal gland agenesis. All our patients presented a series of ocular surface changes, including reduced tear secretion, reduced corneal sensitivity, as well as reduced corneal nerve density. Corneal epithelial defects were detected in all cases. Among them, persistent epithelial defect was noted in 2 adult patients with bilateral lacrimal gland agenesis. The severity of damage is associated with laterality of lacrimal gland agenesis and the disease course. Additionally, we also detected a partial limbal stem cell deficiency in eyes with lacrimal gland agenesis, except a baby who could not cooperate with confocal examinations. Here shows the pterygium and the loss of parasites of Vogt. Interestingly, we found the meibomian gland dropout, especially in the upper lids in eyes with lacrimal gland agenesis, especially those with bilateral involvement. The above observation suggests that congenital lacrimal gland agenesis is associated with pathologies of ocular surface. However, according to our clinical experience, it is rare for adult patients complain ocular surface discomfort after lacrimal gland excision. Therefore, we conducted an animal research and compared the ocular surface after lacrimal gland excision in neonatal and adult mice. Lacrimal gland excision was performed in neonatal mice at 1 week after birth and in adult mice at 5 weeks after birth. All the mice were examined 3, 5, and 7 weeks after surgery. After lacrimal gland excision, tear secretion was significantly reduced only in neonatal mice. Also, significant corneal epithelial defect was detected only in neonatal mice after surgery. Furthermore, meibomian gland orifice plugging, meibomian gland dropout, and abnormal lipid accumulation were detected only in neonatal mice after surgery. PAS staining shows compensatory gallbladder cells density increase only in neonatal mice after surgery. In conclusion, congenital lacrimal gland agenesis is a rare disease, and it is associated with tear deficiency, corneal epithelial breakdown, meibomian gland loss, and partial lymphostem cell deficiency. These changes are correlated with the letality or the severity of lacrimal gland agenesis and the disease course. Our further experimental findings indicate a crosstalk among the lacrimal gland and the ocular surface may exist during the early stage of life. Thank you very much for your kind attention. Good afternoon. I'm Dr. Lin Yiliang from Zhongsha Ophthalmic Center. It's my great...
I think, yes, we can stop there. Thank you. Well, that was an interesting presentation, so it might be something we need to think about in patients, particularly with bad unilateral dry eye disease. So moving along, I'd like to invite the next speaker, and the topic will be ocular morphology and the ocular surface in long-term scleral shell prosthesis wearers, a prospective study, presented by Professor Stuti Misra.
Okay. Yes, I'm not Janice Human. Janice is my PhD student and she couldn't make it. I have no financial interest to disclose, but I should mention Janice and Dr. Keith Pine are owner of New Zealand Prosthetic Eye Services, where these patients were recruited from. It's going on. Yeah. So what is a scleral shell prosthesis? It is nothing but a customized PMMA scleral shell that can be worn over a disfigured blind eye. It has multiple benefits. Obvious ones are obvious, cosmetic and functional. Most importantly, though, in my opinion, is psychosocial and general well-being of patients. For many of them, it's just self-image and social interaction and being part of the society. So in New Zealand, there is definitely an underutilization of prosthetic devices for disfigured blind eye. So we have done a survey and an audit, and that's where we realized there is a huge gap because not every patient is suited for the full eye prosthesis. In terms of scleral shells, and they are quite thin compared to the full ocular prosthesis, and that's why we need more research more clinical research to understand who is best suited for this. So our aim was to characterize clinical features associated with successful scleral shell wear over disfigured blind eyes. And we did corneal sensitivity, ocular morphology, and ocular surface. And these were mostly patients in Auckland and from one center, and mostly from New Zealand Prosthetic Eye Services. Corneal sensitivity was measured using non-contact corneal aesthesiometer and ocular morphology. So we used different dimensions. So we actually measured interpalpebral fissure and also corneal diameter. And ocular surface assessments, including lid viper, epitheliopathy, palpebral redness, and papillae meibomian, were done using Oculus K5M. So we had 60% male and 40% female, and they range from 20 to 83 years. Mostly European, that's just the demographics of Auckland. So Maori, they're indigenous population of New Zealand, and Pacific people, so they're different from different islands, so like Tonga and Raro and Vanuatu and so on and so forth. So most of these patients, they had trauma, so 55%, 40% the medical condition, and only a few had congenital issues. And 16 had their first shell fitting, and 19 has already worn shells before. In terms of corneal sensitivity measurements, of course, there were differences between the eyes, as you'd expect. However, before and after 3 months of scleral shell wear, there was no difference in sensitivity. Although it shows there is, if you look at the graphs, it does show there is a variability, but the p-values were only 0.11. So no difference essentially. Existing shell wearers, they were more used to, and there was no difference at all. In terms of interpalpebral fissure, we also measured, we estimated global volume. That also did not have any spread, any difference before and after using it for 3 months. If you look closely, there is definitely, there's a wide spread, and there are outliers on that as well. Looking at cornea, clinically, we also looked at flattened corneal profile. So currently, we are working and measuring it objectively, so using the silicone ocular impression and contour profile. So we're sectioning it, and we're measuring exactly the flattening of cornea. K5M did not show any changes as well after 3 months between the eyes. Of course, there were differences, but they were after 3 months, we did not show any differences either. So in conclusion, so the two things that are useful in predicting shell tolerance is its sensitivity, just using a cotton bud. And NCCH is not contact is not very useful in detecting these subtle changes, but using a cotton bud, definitely you can, they are quite sensitive to touch. And flattened corneal profile is favorable as well. Thank you.
Thank you. Any questions from the audience? I'll just have a quick one. So do you find that you have to give the patients many topical therapies while they're wearing the scleral lenses?
So lubricants, yeah, generally they're given lubricants for sure, but not generally unless they have an infection, they're not given. But yeah, lubricants are always given.
Thank you.
Thanks.
So could you use the microphone?
I had a case of acute conjunctival glaucoma, which basically presented as a corneal melanoma. It was being treated as a glaucoma, but it was not. B-scan ultrasound showed a solid detachment. It was by this MRI proved to be a case of a corneal melanoma. So I did enucleation. After enucleation, when you put an intraorbital conformer, it increased the intraorbital volume for a couple of 15 days. Then it gives a better fitting prosthesis. So the problem with the children is that enucleation has to be postponed as much as possible, because with the development of the child, the orbit also goes, so you get a contracted socket. So if it's a corneal pathology and there's a pain, so the other modalities which readily has been documented is a secondary shell or a bandage contact lens. Thank you very much.
Thank you.
Yeah, thanks for the comments. Yeah.
Okay, I'd like to invite the next speaker, who will be talking on same-day consecutive bilateral corneal cross-linking, preventing progression while waiting for second eye procedure, and it'll be presented by Dr. Akshlesh Gokal.
Thanks,
I pronounced that wrong.
That's all right. Thanks for the introduction, Stephanie. So my name is Aki. I'm from the University of Auckland. I'm a senior lecturer there. And today I'm talking about a study we conducted to determine whether conducting same-day bilateral cross-linking is a worthwhile endeavor. I have no conflicts of interest. So this is a retrospective cohort study of all the patients that underwent cross-linking in Auckland. This was done between 2013 and 2023. And they had at least 12 months of follow-up. So data was collected for patients who had unilateral and those who underwent bilateral sequential cross-linking. So patients who had bilaterally progressive disease received cross-linking in the worse eye first, the more advanced disease eye, and then qualifying second eyes were waitlisted on the same day to receive the procedure in the second eye, so bilateral sequential fashion. In the public health system in New Zealand, we do have significant limitations on resources, so there was a significant delay between having the first and second eye performed. The progression of the first and second eye was measured over the waiting period. We did this using Kmax and thinnest point. We wanted to determine if progression could have been prevented by doing same-day sequential cross-linking. We collected data on demographics, clinical data, and also waiting times, of course. So we look at the cohort overall. So there's over almost 300 patients. You can see about half of the patients did not need cross-linking in the second eye. So the second eye did not progress, whereas about the other half did. If you look at the first column here, those are the patients that did progress, so they were younger. There was a lower proportion of Europeans in this group, so more Maori and Pacifica, and also fewer Asians. Looking at disease severity, the eyes that did progress had a higher disease severity. So basically from this we can gain that younger age, Maori and Pacific ethnicity, and more severe keratoconus in the fellow eye are predictive of potentially needing cross-linking the other side. And you look at these patients that did have second eye cross-linked. Of course, at baseline, the parameters are going to reflect the protocol, which is the worst eye first. So the second eye had lower disease severity. If you look at the waiting time from waitlist to procedure, was similar, about 4 months, 120 days in both groups. We'll look at how much the condition progressed while they were waiting. They actually progressed by a similar amount during this waiting period. So the Kmax and TC changed a similar amount, but half of them progressed and the rates of change was about the same. However, this situation does change when you look at how it was if you compare the second eye to when the first eye was waitlisted. So again, baseline was the same, but waiting time is about 360 days, so almost a year between waitlisted for the first eye and having the second eye procedure performed. Then if you look at the amount of progression, this changes once again. So you have a much larger amount of progression. This is because the rate of change was actually about the same. So waiting for longer, you're going to have more progression. But interestingly, only 2/3 of the patients actually progressed significantly. So 1 in 3 patients did not really change, even after waiting for a whole year. So if you drill down on these patients that did change versus the ones that were stable, so you can see in the stable group here, the patients were older, unsurprisingly. And if you look at the ones that progressed also, once again, you have a higher proportion of Maori and Pacifica compared to the ones that did not progress. Looking at disease severity, once again, this kind of holds true to the first slide I showed. Disease severity was greater in the group that did progress compared to the ones that did not. Waiting time did not make a difference. So waiting for a year or more than a year did not make a big difference as to whether the patients progressed or not. So effectively, we can say that younger patients are more likely to progress in both eyes, Maori and Pacifica are more likely to progress in both eyes compared to Europeans and Asians, and also having more severe keratoconus would likely indicate that you're more likely to progress. So we can make a few interesting conclusions from this. First of all, bilateral same-day cross-linking does have the potential to prevent significant disease progression, but only in some patients. Remember from our cohort overall, not all second eyes progress in this 1-year follow-up, and meaning not all second eyes needed cross-linking. So if you remember at the first slide, only half of the patients really needed cross-linking the other side, based on their clinical status. And when you look at the second eyes, not all of them did progress significantly while waiting for cross-linking, despite the wait times being quite long. So even if you compare this to the baseline parameters from the first eye was waitlisted, only 2/3 of the patients did progress in this cohort. So effectively, this tells us that bilateral same-day cross-linking may overtreat your population if you have it as a blanket statement. So if you did bilateral in everyone, chances are you're going to overtreat more than half of your patients. So really what this comes down to is you need a more tailored approach to deciding when you conduct bilateral cross-linking. You need to take a number of parameters into consideration, mostly their age, disease severity, and ethnicity. And really more research is needed in this area to predict progression. So things like artificial intelligence and things like that likely will play a big role in this in the coming years. Thank you for your attention. I'd like to acknowledge the rest of the team involved in this research. We looked at all of that. It wasn't in the presentation. The paper covers that, but it was not predictive. So eye rubbing is not predictive of disease progression in this case.
Did you just, in the case of this keratoconus, screen the other family members?
We do that as part of the clinic, yes, but obviously it's not part of this presentation. The oldest person in the cohort was 56. If you remember on the slides there, it had the age range.
Was it based on corneal topography or pachymetry?
Yeah, topography, refraction, vision, all the usual stuff you look at for progression.
We have some other speakers lined up at the microphone, so we might just start. We've got short time, so we might go to one of the others for a question. Yeah.
The good or the Avogadro pulse technique also works. Because what I felt is in pulse Avogadro technique, initially you will feel that they have some progress, but they get settled late, like after 3 months to 6 months. I just want to know your opinion. That is the first question. Second, in post-ectasia patient, which is the best technique to do the cross-linking, whether it is conventional or epi of pulse technique?
So for the first question, accelerated versus traditional protocol, we used accelerated protocol in Auckland as a blanket rule. Looking at the literature, they work very similarly. And when you're working in a public health system where you have a lot of patients needing the procedure done, you can't really spend an hour and a half on each patient, so accelerated definitely. When it comes to corneal ectasia, there's not post-LASIK ectasia, et cetera. There's not a lot of research on that, but I would imagine the accelerated protocol works very similarly. I don't know if Stephanie can comment on that.
So what about thin corneas, very thin cornea, whether it is conventional good or the pulse? Because pulse, very high.
I'll be talking later on pulsed,
Yeah.
one of my presentations on pulse, so maybe we'll leave the pulse till then. Yeah.
Pulse, okay, for
Yeah.
even thin corneas.
Yeah.
Okay.
I'll talk about that later.
Thank you.
Okay.
Did you find what the incidence of this, it was a basal, D-shaped keratoglobus, pellicoid, or other things?
Didn't look specifically at the morphology, but that doesn't tend to make a big difference in keratoconus. The morphology doesn't make a difference. Cross-linking works in everyone.
Any medical associations which you found in these cases?
No, so we looked at A2P and everything like that. The multivariate analysis said none of that was predictive in this case.
The patients were Marfan's, mitral syndrome, and Abdallah.
Sure, if they have the phenotype, if they have the phenotype, yeah.
I was working in the Middle East, I have seen the case of achondroplasia, who had a bilateral keratosis. It was a basically hereditary patient.
Sure.
That is reported very rarely in the literature, so we medical journal. Achondroplasia with bilateral keratosis.
Okay.
Thank you.
Thank
So
you.
some interesting observations. We might move to the next talk just to stick to time, which will be on a pediatric male patient of celiac disease having trichomegaly. And if the speaker's here, it's Sved Gazela Shadawaza. Is this recorded or present? Recorded.
Assalamu alaikum. I'm Dr. Saida Khazala Shahnawaz, working in ophthalmology unit, Rapid Teaching Hospital, Peshawar, Pakistan. There's no conflict of interest to this case. Now, what is my case? My case is a pediatric male patient of celiac disease having trichomegaly. Now, what is celiac disease? A celiac disease is a chronic immune disorder triggered by gluten ingestion, and it results in damage to the intestinal lining, causing diarrhea, fatigue, weight loss, bloating, and anemia. Trichomegaly. A diagnosis of trichomegaly may be made if eyelashes are abnormally long, measuring more than 12 mm centrally and 8 mm peripheral in length. The eyelashes may be curled, may be thickened, and may be with increased pigmentation. This trichomegaly may be the presenting feature of some diseases like Oliver McFarlane syndrome, oculocutaneous albinism, HIV infection, connective tissue disorders, etc., etc. It can be induced by drugs like ditenoprost eye drops, topical drugs, and can be systemic drugs like cyclosporine. Now, case history. My case is a 4-year-old Pakistani male child having celiac disease 3B, biopsy proven, and now on a gluten-free diet, and he was referred to AIOPD KTH for ophthalmology examination in the last year, February 2024. On eye examination, we found that the patient is having photophobia, that he cannot open his eyes. When cyclopegic refraction was done, there was no significant refractive error found. However, the patient was having bilateral anterior blepharitis with sticky eyelid margins. Then on further examination, it was seen that eyelashes were abnormally long and thin, and their length is more than 12 mm in length. The patient was also having allergic conjunctivitis, corneal edema, and however, the other pupil iris details were visible and normal. No cataract was found, no uveitis is examined, and the fundus was also normal. We started the eye management of the patient, and the patient was started on tetrahydrozoline, anti-allergic eye drops, ofloxacin antibiotic eye drops, lubricant eye drops, and eye ointment. QID 4 times a day, and the ointment at night. Also, there was on systemic examination, we found that the patient was a weak, lethargic, irritable child, having weak scalp hairs, lupus hairs, and deeply dry pigmented skin. And also the whole body showed scaly dermal lesions on the scalp, neck, back, legs, and feet. This was a systemic examination. And when we see the investigation, the report shows that he was having hypocalcemia, hypophosphatemia, urinary tract infections, and dysentery. On treatment, the patient was put on gluten-free diet by the nutritionist and the pediatricians, and was also having IV antibiotics, vitamin D injections, and multivitamin syrups. Then on follow-up visit of this patient, on follow-up visit, the patient ophthalmological examination was dramatically improved, plus the systemic examination was dramatically improved. And so the treatment or the goals of our treatment were achieved, that we decrease the patient photophobia and we cure the patient anterior blepharitis. So the takeaway message is that the pen torch examination of each and every newborn child is must in hospitals, especially in the gynecological and in the pediatric units, and then early referral to these patients to ophthalmology units for early diagnosis and treatment of the eye diseases. Thank you. Shukriya. Bismillahirrahmanirrahim.
Okay, well, that was a very interesting presentation as well, and reminds us always to look out for systemic disease in patients with ocular signs and vice versa. So the next speaker, Andrew Vendrev, is going to talk on collagen-based artificial cornea, comprehensive in vivo and clinical case studies. Is this also recorded? Or there's no talk, no speaker? Yes, yes.
And the other thing is that this posterior unlock, what do we call trachomegaly? They cause congenital hyperemia, congestion, allergic conjunctivitis, loss of perioperative fat, and cystoid macular degeneration. So if you have a patient of a glaucoma,
only not present.
posterior unlock should be avoided.
Okay, thank you. Okay, do we have, so this current talk will not go ahead. Do we have the next speaker who's talking on clinical performance of 2 daily disposable toric soft contact lenses, Verifilicon versus Etafilicon A, and this is from Anjara Parameswaran.
Thank you. Yes, I will be talking on this study, clinical performance of 2 daily disposable toric soft contact lenses, Verifilicon A versus Etafilicon A. Disclosures, this study was funded by Alcon Research, and the presenter is an employee of Alcon Medical Affairs. Comparing the 2 commercially available clinical performance is the objective of this study. The 2 daily disposable toric soft contact lenses, which is Verifilicon A, which is a silicon hydrogel daily disposable contact lens, which has been reported to have high ratings in terms of vision quality, comfort, and handling. Etafilicon A is a widely used conventional hydrogel contact lens that has been available in the market for a long time. The methodology used in this study is it was a randomized, prospective, controlled, double-masked crossover clinical study conducted at 8 sites in the US. The subjects who were eligible were randomized in a 1:1 fashion with a single crossover to bilaterally wear Verifilicon A toric lenses or Etafilicon A toric lenses for more than 10 hours per day for 8 to 11 days in a daily disposable modality. The inclusion criteria included subjects more than 18 years of age who were successful wearers of toric soft contact lenses in both eyes for more than 5 days per week and more than 10 hours per day during the past 3 months. They should also be willing to wear the lens for more than 16 hours per day on one of the days. On or after day 7 of the study lens wear, the subjects were asked to wear the lens for more than 16 hours on one day to complete a take-home questionnaire. This is to understand the preference for long wearing time. This follow-up included 4 study visits. Visit 1 was a screening or the trial lens fitting visit. Visit 2, baseline and dispensing of lens 1. Visit 2 is a crossover to lens 2, and visit 4 is a follow-up or the exit visit. The primary endpoints was distance visual acuity at week 1, with the exploratory endpoints being subjective ratings for overall preference at end of study, subjective ratings for insertion handling, insertion comfort, and overall comfort at 16 hours, lens position at week 1, and lens movement at week 1. The analysis for statistics was used using the SAS software, and a mixed effect repeated measures model was used to test for visual acuity and the subjective ratings. Overall, 112 subjects completed the study, and the mean age was around 32 years, with 61% being female. The primary results, which was distance visual acuity at week 1, there was the Verifilicon A toric soft contact lenses were non-inferior to Etafilicon A toric lenses. The exploratory endpoints being overall preference for Verifilicon A. Of the subjects who reported preference, 63.3% preferred Verifilicon A toric lenses at the end of the study. Looking at the subjective ratings for insertion handling, insertion comfort, and overall comfort, Verifilcon A toric soft contact lenses had a higher rating than Etofilcon A toric lenses, which was statistically significant across all the 3 parameters evaluated at the end of 16 hours. In terms of lens fit evaluation at week 1, both toric lenses demonstrated optimal lens centration or acceptable decentration and optimal or acceptable lens movement in both primary and peripheral cases. To conclude, Verifilcon A toric soft contact lenses perform better than the Etofilcon A toric lenses for insertion handling, insertion comfort, and overall comfort at 16 hours. Both the daily disposable toric soft contact lenses showed optimal lens centration or acceptable decentration and optimal or acceptable lens movement at week 1. Thank you.
Thank you. Any questions on the presentation? Otherwise, I might ask. So if a practitioner is trying to decide between the 2 lenses, does that sort of suggest that both could be a choice, or would you be moving more towards the Verifilcon?
So what we were looking at for long-term wear for a daily disposable lens, at least the key endpoint, which was observed at 16 hours, wearing the lens for 16 hours was one of the key findings. And we found that more than 62% of patients preferred wearing the Verifilcon A versus the Etofilcon for a long-term duration wear. Although we suggest for 10 hours, patients tend to wear it for longer duration. Hence, this would be a preferable. The comfort after wearing for long duration was better with Verifilcon A.
Yeah, good, thank you. And it looks like the whole concept of the toric contact lens is working better because in the past they've rotated a lot and patients haven't always found them easy to use. What is the highest cylinder that
I think a 1.75 we do have.
Okay.
Minus 2. Yeah.
Minus 2.25. So,
yeah.
Okay.
Thank you.
Thank you very much. Okay, so we'll move to our next talk, which is implications of conjunctival dysbiosis in immunoglobulin G4-related ophthalmic disease by Kamjong Kelvin Chong. Is this recorded or in person? The next one? Okay, moving right along. So the next presentation is actually by me. So I'll move up to the pulpit. Okay, so I'd like to thank my co-authors who are shown on the slide here. And this presentation will be on the 12-month outcomes of pulsed corneal cross-linking for keratoconus, a SaveSight keratoconus registry study. How do we advance? No? Okay, and I'd like to acknowledge the Kornhauser Research Associate Funding and the Ophthalmic Research Institute of Australia. So what is pulse cross-linking? Well, this is when you use a pattern of intermittent pulsing of the ultraviolet light during cross-linking. Typically, it's 1 second on and 1 second off, though there are varieties in the timing of pulse cross-linking. And the aim here is to prevent the depletion of oxygen with continuous UVA exposure, because it's thought that oxygen is an essential component of the reaction that creates reactive oxygen species that then interact with proteoglycans in the cornea to create the crosslinks. Accelerated cross-linking protocols vary, and energies between about 9 and 30 milliwatts per centimetre squared have been used. And it's thought that pulsing may be used to optimise clinic workflows through allowing a shorter treatment time. So we conducted a systematic review to look at the evidence for pulse corneal cross-linking. 29 papers were found, including 14 which we selected for meta-analysis as they had the necessary data. The primary outcomes was looking at maximum keratometry and vision, and we looked at some secondary outcomes as well. This work was done by Maria Qureshi, a medical student, and supervised by Himal Kandor, the postdoc in my group. And what we found for the systematic review, including all articles, that at 12 months compared to baseline, pulse cross-linking did result in a reduction of Kmax of around minus 0.75 diopters mean, and did improve corrected distance visual acuity, though by a very small amount. But looking at the meta-analysis, there was no significant difference between pulsing and conventional. And for these two groups, when we looked at protocols being done with equivalent fluence, that keratometry Kmax was the same at baseline as final follow-up, and visual acuity was also the same. So from the published evidence with this meta-analysis, we concluded that intermittent pulsing in higher energy cross-linking protocols renders statistically similar outcomes as continuous light exposure at an equal fluence of 7.2 joules per centimetre squared. So we wanted to know, well, what's happening in the real world? What is the safety and efficacy of this procedure of pulsing, and how does it compare to conventional? Using the SafeSite Keratoconus Registry, which is a global database of patients with keratoconus, including those that have also undergone cross-linking, we collected data relating to their demographics, medical history, clinical findings, and also quality of life assessment with the cork. The SafeSite Registries is currently available in a range of countries. And how it works is practitioners put in data from everyday practice on their patients, and this generates a graph that can be used to track outcomes while the patient's there, and you can also get reports that summarise the outcomes of your everyday practice for keratoconic patients. This particular study had data from 18 practices in Australia, New Zealand, Spain, France and Italy, with the data entry being able to performed in around 60 seconds for all visits. And after that went in, the real-time summary was produced for each patient. We had a lot more patients undergoing conventional cross-linking, 386 patients with 465 eyes than pulsed. We had 50 patients having pulsed with 72 eyes. The mean age in the patient groups was similar, though slightly older in conventional, and there were similar rates of males to females in each group. So what was the mean change at 12 months in visual acuity? And this is habitual visual acuity. There was a greater change with conventional than pulse, but this did not reach statistical significance. Similarly with pinhole vision, there was an improvement for both, but it did not reach statistical significance. Kmax had only very slight change indicating stability. K2, slight change. And the minimum corneal thickness was slightly thinned in both groups, but none of this reached statistical significance. Adverse events were seen slightly more in the conventional group, with a greater number of patients having clinically significant haze. All over, we had more adverse events in the conventional group, but this group did have a lot more patients. Corneal scarring was seen around 6% in the conventional, keratitis in the conventional, steroid response also in conventional, with herpes simplex in the pulsed and stromal edema occurring in the pulse group. Other less common adverse events included high drops, sterile infiltrates, corneal neovascularization and recurrent corneal erosion. So in conclusion, the registry was an easy-to-use tool that we were able to use to collect a large amount of data from keratoconus patients in the real-world setting. And we found that pulse cross-linking was associated with comparable visual and keratometry outcomes to that of conventional, though clinically significant haze was less common in pulse than in the conventional. Pulse cross-linking outcomes require ongoing tracking of their treatment, and this can be facilitated with the registry. I'd just like to thank by thanking the researchers involved at the team and also the registry team. And if anyone would like to join the registry, they can. It's for free. Thank you. Any questions? Yes. Oh, sorry. Could you use the microphone so everyone can hear?
In patients with one-time failed cross-linking, what is the best technique to use?
So if they've failed cross-linking, I always find out what was the technique they had originally. You know, particularly if it was epithelium on or done in a way that may not have been as effective. This study didn't seek to address that question, so I don't have the evidence base for that. I think there's some limited studies on that topic, but generally I'd probably perform conventional.
And if the Kmax is more than 65 or 68, but still the corneal thickness is good, can we do cross-linking even if the chance of failure is more?
Again, this study didn't look at what the chance of failure was in relation to the keratometry, but the steepness isn't a contraindication as long as there's adequate corneal thickness.
Thank you.
Sorry, could you use the microphone so people can hear?
The incidence of the complication in this condition.
So the question is about the incidence of the complications in the two groups. It was slightly higher in the conventional because there were a lot more things that happened just once. But I think there was quite a big, there's a big difference in the number of patients. Clinically significant haze was more common in conventional, but that's often thought to be a sign that the treatment has actually worked. Okay, thank you. Thanks to me. So back to the last presentation now, which is on ocular mucous membrane pemphigoid presenting as recurrent pterygium, and this is from Pomina Golethi. Thank you. We're just setting up for that. Just a few technical issues, but luckily we're running ahead of time, so we can all relax.
Good morning, everyone. I'm
Okay,
presenting.
we're going to start now. Yep,
yeah,
thank you. Everyone, we're about to start.
Ocular cicatricial pemphigoid presenting as recurrent pterygium. So, ocular mucous membrane pemphigoid is a chronic disease. It results in sight-threatening complications with increasing rates of severity. From subconjunctival fibrosis, for lower pharyngeal shortening, symblepharon, ankyloblepharon, ectropion, entropion, and trichiasis, and even corneal scarring, which leads to irreversible vision loss. So a high degree of clinical suspicion is required for the diagnosis of ocular MMP because delay in institution of the therapy can result in disease progression, which is often irreversible. So the diagnosis is confirmed with direct immunofluorescence of the conjunctival basement membrane. Coming to the pterygium, it's a very common fibrovascular degeneration of the conjunctiva with a global prevalence of 10 to 12%, with having greater prevalence in the tropical areas due to increased exposure to UV rays. The surgical excision of the pterygium is a primary modality of therapy, with the recurrence rates being 2 to 90% depending upon the type of surgery. The recurrent pterygia have not previously reported as a finding of ocular MMP. Hence, in this case series, we are presenting the recurrent pterygia like ocular MMP as a presenting finding with recurrent pterygia. The purpose of the series is to report the recurrent pterygium as a presenting feature of ocular mucous membrane pemphigoid. So this is a retrospective review with biopsy positive ocular MMP were included who presented with recurrent pterygia. And we have excluded all the other causes of cicatricial conjunctivitis like ocular burns, SJS, patients on medications like gliptins, which are anti-diabetic medications, and anti-glaucoma medications were all excluded. So all the patients had undergone a detailed ocular examination, assessment of best corrected visual acuity, slit lamp examination of both the anterior and posterior segment. The grade of pharyngeal involvement was based on Montino-Brown staging system. And all the patients who presented with recurrent pterygium were underwent a conjunctival biopsy from both the eyes to confirm the diagnosis of ocular MMP by direct immunofluorescence using a standard procedure. So these are the results. There are a total of 5 patients with recurrent pterygium were included in this study. You can see the 2 of the patients are younger than 45 years of age, which is unusual for the presentation of ocular MMP. Because of the second surgery, it might have triggered an autoimmune response in ocular MMP, so it has presented earlier than the usual. This is the first row is showing the case 1 with both bi-headed recurrent pterygium with symblepharon, and the direct immunofluorescence picture is showing the positivity for immunoglobulins. And the second row is also showing the recurrent bi-headed pterygium with lower pharyngeal shortening with symblepharon. And this is the direct immunofluorescence image showing positivity for C3 along the base membrane of the conjunctiva. These are the 4th and 5th patient pictures showing the same, the temporal recurrent pterygium with DIF positivity. This is a 5th patient's picture showing the corneal scarring and lower limbal stem cell deficiency with symblepharon inferiorly and also the lower pharyngeal shortening. So this table is showing the clinical features at presentation, immunofluorescent findings, and management details of all the 5 patients. Out of which, it is showing recurrent pterygium with severe fibrosis and symblepharon in 4 out of 6 eyes, which is almost 67%. indicating the presence of recurrent pterygium with symblepharon, we need to rule out ocular MMP. So usually the presence of pterygium with symblepharon is usually rare. It is usually 7% in the literature. But in our study, we have found 67% of the cases had the recurrent pterygium with symblepharon. So all the patients were subjected to direct immunofluorescence, which gave the positive results in all the patients. And we started them on immunosuppressive therapy with oral prednisolone, 1 milligram per kg, tapered over 6 weeks, and methotrexate, either methotrexate or azathioprine. So the key takeaways are meticulous preoperative ocular examination is necessary in patients who are planned for any ocular intervention. Specifically, the inferior fornix, presence of fornical shortening, conjunctival fibrosis, and symblepharon should be ruled out. This principle can be extended to any conjunctival surgery that has an abnormal fibrotic response during the postoperative recovery. This is particularly relevant for patients with ocular MMP because ocular MMP triggers an autoimmune response early if we have any surgical intervention without any immunosuppressive therapy. Thank you.
Thank you. We have a question, if you could use the... Oh, yeah, okay, great. Okay, excellent. We'll just, we've got time, so we'll just see if there's any questions there, because that was something that I wasn't aware of, so I think there's some good learning points for everybody there.
Thank you.
Yes. Any questions related to the talk? How long did you continue the immunosuppressive therapy for?
Till 6 months we have continued.
6 months,
Yes,
okay.
yes.
And then after
and
that?
all are doing well. We have followed up the patients till 6 months and they are doing well.
Okay.
There's no progression of ocular MMP.
No, very interesting. Yeah.
Thank you.
Okay, so we've got the 12th speaker, which is good.
Thank you very much. Thank you very much.
So this talk is from Kenneth Lai on the implications of conjunctival dysbiosis in immunoglobulin G4 related ophthalmic disease.
Thank you very much for the introduction. I'm an oculoplastic surgeon by training. I'm chairing another session next door. So I'm presenting on my behalf of the first author, who is my fellow, and we jointly conduct this study in Hong Kong. So this is a territory-wide study in Hong Kong. There's no relevant financial disclosure. This is a joint effort of 9 hospitals. So we in fact, have a Hong Kong IgG4-related ophthalmic disease cohort, and there's a number of papers you can refer to. In fact, 6% of our patients who are biopsy-proven IgG4-related ophthalmic disease, they develop optic neuropathy with permanent visual loss. 13%, importantly, develop cancer over a long, extended period of follow-up. Most of them have lacrimal gland disease, and 2/3 actually are steroid dependent, and they have a lot of dry eye issues. What we were trying to look at as an oculoplastic surgeon when we managed them, and we figured out that many of them has very refractory dry eye disease, not just lacrimal, but also meibomian gland evaporative component. So that's why we were looking into something else. So we were, again, looking into the literature talking about the relevance of conjunctival microbiota. But conjunctival microbiome has never been studied in IgG4-related ophthalmic disease. And we were thinking that perhaps it could be a clue of why these patients have so refractory dry eye. So we call back our patients who are biopsy-proven, and at the same period of time, we arrange gender and age match healthy control just to compare at the same setting. For those colleagues who are not too familiar with conjunctival microbiome, you need to do that at a very similar period of time and setting because environment makes a lot of difference. So we have that. And we use the standard diagnostic criteria. All of them were published in a number of reports before using the standard diagnostic criteria. Essentially, one of the ophthalmologists, the fellow himself, he's doing this without any topical anesthesia. It's a little uncomfortable, but bearable. We were actually using a swab that helps to get some of the microorganism 3 times over the inferior fornix and then put them together. One of the problems of doing conjunctival microbiome is because conjunctiva is otherwise considered clean, I wouldn't say sterile, so we call that a low biomass. It's very hard to get microorganism or nucleic acid compared to like gut microbiome from stool. So we put that up, and then we used a very standard, widely accepted method of 16S. This is a microorganism type of RNA gene, not human. So we're not sampling human. So from that, we pull up the library. And this is a baseline background information of the cohort itself. It's not the whole cohort, because we want to figure out things have to be done within a short period of time. It's over 4 weeks. So we managed to call back a couple of them. The essential findings here in the study is a number of bacteria, bacteroides. Firmicutes, cyanobacteria are significantly increased compared to age and gender match control, while proteobacteria is decreased. The key finding is bacteroides were positively correlated with the number of extra ophthalmic organ. That's something as ophthalmologists of much relevance. I'm going to run through the final slide. The positive correlation between of the bacteroides to the extraocular or systemic organ involvement will be our key finding, because nowadays oculoplastic surgeons rely on PET scan to have a systemic workup before we refer to our rheumatologist or hematologist. Now that this conjunctival microbiome might be a clue, we want to make sure that in our untreated cases, I haven't go through my limitation. These were treated stable patients. So for incident cases, new cases, perhaps in future, conjunctival microbiome might give us a clue for patients with eye disease presenting to us, oculoplastic surgeon, that they might have underlying extraocular systemic involvement. Thank you very much.
Thank you. Any questions? Thank you. So it is, you've got to go. Oh, no, I was just going to say, look, it's very tricky sampling the conjunctiva for microbiotome. Do you think that's going to be able to be done clinically, like in wider settings, or does it sort of need strict protocols?
That is probably like our gastroenterologists. Once they find out a specific species will be relevant for, say, colorectal cancer, they're not doing the microbiome itself, but to look for that species or a particular metabolite, usually short-chain fatty acid that is relevant, because these will how these microorganisms affect us. So perhaps once we establish that, then we can actually look for that particular species or particular metabolite that is relevant pathologically to the IgG4-related disease.
Mm-hmm. Okay, thank you. Okay, I'd like to close by thanking the audience, thanking the speakers in the session, and I hope everybody enjoys the meeting here in Delhi. Thank you.